Welcome to another episode of Brain Buzz. I'm your host, Dr. Iman Moeini.
And I'm your co-host, Jason Wallen.
Today we're going to introduce another member of our team. Not so new, but
A little late to the party.
A little late, but we waited for him to get acclimated and see if he really liked it here.
Yeah, exactly. Almost a year, but that's okay.
Yeah, before we introduced him, but never too late. And that's Dr. Moeini. Thank you for being here. And Iman came to us not far. He came to us from Westchester, where he completed his training and joined us as our fourth neurointerventionalist at Good Sam, our comprehensive stroke center. And I think brought a unique expertise, and we'll talk a little bit about that, to our practice and to the hospital. It also, his addition made us, I think, one of the most diverse neurointerventionalist teams because we have all specialties represented.
That can all lead to that path.
Lead to neurointervention. We'll talk about that in a little bit. But again, Iman, thank you for being here, and thank you for joining the Stroke and Brain Aneurysm Center of Long Island. Talk to us a little bit about what led you to Long Island, to our program, and kind of how that decision unfolded.
Thanks very much, Kimon. I'm very excited to be here with you and Jason. And I was thinking this morning I couldn't ask for any better time to be on this podcast. It's Stroke Awareness Month.
Right.
So I think
that's why we waited.
Yeah. The perfect timing to be here. I basically talking about different training background in this field, in the field of neurointerventional surgery. The people have different training background. You can come from neurosurgery training, radiology, and neurology. I did the neurology pathway. Mm-hmm. I did residency, 4 years residency in neurology, followed by vascular neurology fellowship, and then the neurointerventional surgery fellowship. And I completely agree. We have a group of diverse neurointerventional surgeons with different background training, so it's very helpful when we discuss cases amongst ourselves.
Right, and the interesting thing is that of course Iman comes from neurology. He's got other colleagues that come from other principles, but we all practice the same at the end of the day. But there's also benefits of having these different backgrounds because Iman, which is a common theme with all the doctors that we've brought through from our team that we've brought through the podcast, they're all extremely qualified and overly trained. Mm-hmm. Iman did a residency, then did 2 fellowships, and eventually became a neurointerventional surgeon. So, they're overachievers to begin with. But then, you have somebody coming, say, from the field of neuroradiology, and, they're experts a lot in the imaging, the devices, all the specifics of the radiological part of what we do. Then you have somebody coming from the field of neurology. They're very much experts in terms of the field of stroke itself, blood vessel problems, understanding those pathologies. And you have somebody coming from neurosurgery. They're more of an expert in the open stuff and the more involved surgeries, but also the technical aspects. So you have that cross-pollination of training that makes our program great. And so you train in neurology, right? And why did you decide? I guess let me backtrack. Was it your decision to go into neurointervention? Was it there from the beginning, or while you were in neurology, you said, you know what, I like neurointervention, this is the path I need to take?
Yeah, I get that question very often. I always knew I like to deal with neurological conditions. So even from the very first day I started the medical school. But more specifically, I got really interested in neurointerventional surgery because I realized it is one of the most rapidly evolving and one of the most impactful field of medicine. You will be amazed by looking at how far we have come in this field over the past 10, 20 years.
Okay.
Some of the procedures that we do nowadays could not be even imagined 20 years ago.
Right.
And that tells you how uh, revolutionary was this field, basically. I would put it this way. So that made me really interested.
Right. And I think the field was created as you were going through training, right? It's not something that existed and you had a choice. You said, oh, I want to go here or there. It wasn't an established field. Now, of course, we were more into the establishment level. Still a lot of exciting things are happening, but as you were training, this thing was in its infancy. And so I think you had the opportunity to kind of ride the wave as it was happening. And of course, you're interested in stroke, otherwise you wouldn't be in neurointervention. And of course, from neurology, there's a deep-rooted understanding and expertise in stroke. And you did vascular neurology, of course, and so that speaks volumes. But tell me what attracts you to stroke. Is it the pathology? Is it the impact you have on patients? Kind of how you can change somebody's life in a minute, and how, and you kind of alluded to it. How has stroke care changed over the years? Because stroke used to be an afterthought in terms of treatment, and now it's one of the biggest areas that we focus in the emergency care of patients.
Yeah, what really interests me in stroke is, first of all, the pathology of the stroke. Like anyone come to the emergency room with a stroke, yes, they have a stroke, but the next step is to find out why they had a stroke.
Right.
There are different categories of etiologies resulting to stroke. So that's what you do a lot in the neurology part of the stroke, to find the etiology and tailor the treatment regimen based on the etiology of the stroke, whether
Right.
it was like atrial fibrillation or carotid disease, small vessel disease. So that's kind of like problem-solving game always was interesting to me.
Right.
And then when you come to the procedural and surgical side of the stroke, which is all the surgeries that we do, including the mechanical thrombectomy,
Mm-hmm.
what really amazes me is the outcome of these cases in most of the, we don't get perfect outcome
All the time.
all
right.
the time. Yeah, that's something that we know. But if you look at the treatment of the stroke, like 20 years ago, maybe 30 years ago, there was like very limited options for treatment of stroke. But then we had all of these trials in 2015, the Big Five trials.
Yep.
As a result of that, we had mechanical thrombectomy as a recommendation in American Heart Association guidelines. So that showed the promising result about the safety and efficacy of the mechanical thrombectomy, and more trial came out. Now we do this procedure up to 24 hours. It was
Right.
initially only 6 hours.
Right.
So if you follow all of these clinical trials, you see how the path has evolved.
Right.
And one thing I really like about the surgical treatment of the stroke is the teamwork
Right.
involved. So when someone comes with blockage of one of the large arteries in their brain, they come to us with a stroke.
Mm-hmm.
We only have a few minutes from the time they come to the emergency room to start the procedure.
Right.
Because we are losing almost 2 million brain cells every minute.
Wow.
In someone who has blocked large artery in the vessel. And that tells you how time sensitive is
Mhm.
the procedure. So I work with a team of people, including the EMS personnel, ER doctor, nurses, nurse practitioners, radiology technologies, everyone. These are the people who are trained to work under intense pressure.
Right.
And it's with the help of this team that you can make the thing happen, and you can transfer the patient from emergency room within few minutes to the angio suite. And when everything goes well, you see how rewarding is the result.
Right. I completely agree, and we've done a lot of videos on mechanical thrombectomy here. But if you're new to the channel, what Dr. Moeini is referring to is our ability to go through the artery in the wrist or the leg, navigate our catheters and wires all the way up into the brain, and remove those clots that cause the blockages and the strokes mechanically. And that, like he said, it's a revolution in our field because it hasn't been around for long. It's been around for about 10 years in terms of a standard of care. and it took off the latter part of those 10 years. I'd say in the last maybe 7, 8 years, it really became the mainstay of treatment. And so, of course, you're describing an emergent scenario where the adrenaline is flowing and things are happening fast. What personality traits do you have, or should somebody have, to deal with such life-threatening problems, life or death scenarios, and of course situations where you have to hurry, but you can't be rushed, right? You got to be calm at the same time as trying to save somebody's life. So what are the personality traits that kind of you found that I guess you discovered you had to be in this field, or other people should have to consider this?
I think the most important one is being able to work under intense pressure. Some people, including myself, when I am dealing with a stressful situation, usually my concentration, my focus, everything works better. So it's
Right.
kind of like it's a perfect setting for me
Right.
to start think clearly and concentrate. This is something that you need to have when you're dealing not only with neurointerventional surgery, I think with any surgical field or any sort of job that deals with the stress. So I think this is the number one trait that
Right,
you
and
need to
it's
have.
that's very, very insightful, and it's not for everybody. Obviously, some people under that extreme stress will not be able to perform. It'll have the opposite effect. But there's few folks that under tremendous stress, their focus becomes laser targeted, and they're very sharp, and they can make decisions. It's not like you have a lot of time to make these decisions, and
Exactly.
the decisions are are life and death decisions, of course. So that's it's a really, really particular trait, I think, that those folks have. And so stroke doesn't come during work hours only, and I'm sure you get woken up a lot. I know that, for stroke calls. When you get woken up in the middle of the night and you look at the films, I'm sure, and you say, okay, we got to go. You call the team in. What is going through your mind? You're driving in that short few minutes in the middle of the night, 2 a.m. What's going through your mind as you're going to the hospital to treat this patient?
So first, I usually run the whole case in my mind before I get to my car, start driving to the hospital. I've already looked at the films on my cell phone, and I know some history. So I basically try to come up with a good plan. Not only one plan, plan number 2, plan number 3. You always need to have a backup. So you do this like basically mental exercise every time that you go for a case. But then after that, to answer your question, I always think about the family of that person, like how many people are involved because of this one person having a stroke. Because in the operation room, you only see the patient and you're only dealing with the patient. But after the surgery or the day after surgery, when you go to the intensive care unit and you see the patient and family over there, you just realize you're not dealing only with one person. You're basically dealing with the whole family that sometimes can be multiple families involved. And I always keep that in mind, that each of these patients are someone's
A loved one.
Yeah,
Yes.
loved one. Yeah, exactly. So
Yeah.
we don't see them in the operation room, but they are waiting somewhere for us to give them a good news.
And those are all phenomenal points, right? So first of all, Dr. Moeini mentioned the plan. Any high performer in medicine, in sports, in any field that there's stress and pressure involved, plans. You always plan. There's no such thing as spontaneity, or there's no such thing as winging it. Even if you wing it and it works once, it's not gonna work consistently. So I think if you ask almost all neurointerventionalists, the first thing they do is plan. And if you're driving in, you're thinking of the devices you're going to use, you're thinking of the case, and you're thinking of option 2, 3, and 4. Like you said, you're thinking of the backup. There's always a plan and a backup plan and a backup plan, because it's somebody's life. And then the second point you made is amazing. the patient is the patient, but it's not just the procedure for us. It's our ability to help a family, and that's really our focus when we deal with these patients. And of course, we always try our best. Outcomes are most of the times great, but sometimes the disease is the disease process, and there's not much we can do despite our best efforts. And that's a tough situation because we're all used to giving our best and changing people's lives. And how do you deal with that when sometimes, unfortunately, that also happens?
Yeah, I think I've learned over the years of training and work that you always have to prepare yourself for hope for the best outcome, but prepare yourself for the worst outcome.
Right.
And I think that's the mentality you need to have. First of all, you need to have multiple backup plan. This is something that started with my job, but now I see that I'm doing it in my real life.
Right.
People around me, they're like, okay, that's enough. We're going to do it. It's going to be straightforward. And most of the time, I'm like, no, we need to have a good backup plan before we start this. So despite having all of these backup plans to get out of any complications, some complications happens. It's a part of our job.
Right.
And despite doing our best, there are cases that we cannot get the optimal result. So the only thing that can keep you calm during or after the procedure is that you have done whatever you could.
Humanly possible.
Yeah, exactly.
Yeah, that's actually very comforting. All right, let's switch gears. Let's talk about, we said neurointervention, of course, is at the cutting edge of medicine to a large extent. And let's talk about all the cool new things that are happening every day in neurointervention. And I know there is a national international craze about artificial intelligence, of course. But, we've been using artificial intelligence quietly, I guess, in stroke and neurointervention for, I don't know, over 5 years now, even more.
We've been slowly implementing it as
Yeah, so tell us a little bit about how we use AI in the care of stroke patients.
I think it's an exciting topic in our field. And as you mentioned, Kimon, we use AI on the software that helps us to detect aneurysm, detect large vessel occlusion, bleeding in the brain. And since we started using these over the past few years, you can see the advancement in these detecting systems.
Right,
At the end of the day, it's a physician decision and the provider decision on how to interpret this information.
Right.
We still do everything old-fashioned, looking at the films, looking at the CT angio, CT head. I don't think we are there yet to fully rely on the AI result. So again, at the end of the day, it's a provider call. But it's interesting how the suggestions you get from the AI, sometimes they match with your impression, whatever finding you had from the imaging. You see that AI suggestion is pretty close to that.
Right, and I think what you pointed out is spot on. Artificial intelligence, the same way, it's coming a big wave. In the same way the internet came and all the other advances in technology, they are just adjuncts, and there are points of information that help you make the final decision.
Exactly.
And it's difficult to substitute that clinical judgment and that understanding of risk, benefit, reward, and technical result in your hands for a patient. And so these decisions, of course, I think artificial intelligence, we've been using it for a long time. It's extremely helpful. It helps us determine what parts of the brain are dead, and it helps us determine the salvageability of the brain. It helps us determine if there's large blockages. It helps us look into areas where there's areas of concern. It points us in the right direction. But at the end of the day, it's just another piece of data that we consider with multiple other pieces of information to make the final decision. And that's why you have neurointerventionalists and programs of different talent and quality.
for sure.
At the end of the day, it comes down to the person interpreting the data.
Well, they say that you should use AI as more of a tool to
Right.
get to 80% of your task. If you can cut out, like in the way we use it, it's going to go through all these images. You know, even for a CAT scan, think of how many images are in a CAT scan, but it's going to give you the couple frames that you need to focus on first. But you might have to go back a couple to get the whole story, go through it yourself, but at least you know where to focus, and it's saving time.
Definitely.
And that's really where, in medicine, where we find the best.
And that's
use of
important.
it.
Time is brain. We've said that about it. We've said about this a million times. And yeah, so what are you thinking? Of course, there's a lot of other cool things happening constantly in neurointervention. What do you think the future holds? Anything exciting coming in the future for our ability to treat things in the brain through the arteries?
There are every year or so, there's basically a new indication. There's a new condition that we can treat with like endovascularly. Recently, over the past couple of years, we had all of these trials, very promising results for treatment of chronic subdural hematoma with medial meningeal artery. That was something that we were not talking about like 10 years ago.
No.
But now we're doing it everywhere, basically. And it's been shown to be, the safety and efficacy has been very acceptable.
Yeah.
Same thing with other procedures. There are, for example, there are upcoming studies about using the medial meningeal artery for treatment of the headache,
Okay.
like refractory headaches.
Okay.
This is just an emerging idea, and most of the studies are experimental studies, but the result from the research results so far has been very promising. We will need more research, more clinical trials to find a better patient selection criteria for this procedure. But basically, yeah, that's one of that's another new indication for patients who have refractory headaches that are not responding to the medical management. We can consider this. And again, it is not meant to replace the medical treatment. There are multiple FDA-approved medications for treatment of headaches, and we only consider this procedure only if the patient failed those medications.
And that's something that we've recently been doing at the center based upon the current criteria. Like you said, it needs to expand more based upon the trials, but we've had great results, I think, with even with what we've had now and what we've done so far. Don't you agree?
Yeah, definitely. What about neuromodulation? Do you think we'd be able to control function through stimulating the brain, but endovascularly, like with stents and other stuff? I know that people have been trying to.
Yeah, exactly. It's kind of a same thing. It's a emerging idea with some promising results, and I think all of the procedures we do nowadays, they started from these early steps.
Right.
We just need like more and more clinical studies to show the efficacy and safety. But yeah, that's also another indication.
Awesome. So tell us a little bit about yourself. Of course, when we bring a doctor here, we always, our viewers and listeners, they want to know more about who you are. And of course, a large part of your life is taking care of patients, but it's not the only thing you do, obviously. And so tell us a little bit about what you do outside of work.
That's my favorite question.
It should be an easy one, right?
Yeah. I try to spend as much as I can with my family, my kids. I have a son and daughter and my wife. So basically, as a neurointerventional surgeon, the most part of our job is dealing with emergencies. So when I'm not on call and I have protected time, that's my number one priority, to spend time with family. We recently moved to Long Island, so I'm pretty new to Long Island South Shore. We like it pretty much here with all the beautiful beaches on the South Shore. That's something. Winter was pretty harsh, but waiting for the summertime. Yeah. So
you came at the end of the summer, and then it's been one of the worst winters we've ever had.
And it doesn't seem like it's ending.
It's snow
May
for months,
and it's 60 degrees out, like low 60s, which is not the typical May. How do you deal with, because you have little guys? So when you are on call and you might be doing something and you have to be pulled away, either just in the moment to review films or talk to somebody on the phone, or in the terms of a true emergency and just completely step away. How do you deal with that with the little guys? Because everybody, when you have bigger kids, you can just be like, look, you get it. We've been doing it for a while, but you have like real little guys. So how do you deal with that and manage that?
Yeah. Yeah, that's actually one of the challenging parts every time I get a call, because it takes me a few minutes to explain to him that like we're playing, and then something comes up. I check my cell phone. I come back again, and then a few minutes after that, I have to leave the home. So yeah, it takes a while to come up with a good technique to explain to them. Obviously, they cannot realize all the aspects of the job, but I try, when I'm not on call, I try to compensate for any time that we missed during an emergency.
Try to make the most of it.
Yeah. One of the first words that my son ever said was emergency.
Okay.
Yeah, he used to say emergency, but yeah, it was one of the first mom, dad, and then emergency.
My son's 16, going to be 17 soon, and I've been in this field for so long that even when my phone goes off, like yesterday, we were going to watch a TV show together, and I'm coming up the steps and I'm doing something on my phone, and he goes, "Oh, do you have to go to work?"
Yeah.
And it's like, oh man.
Yeah. It's a little bit of trauma.
I didn't, but it's like, oh man, like they're trained.
Yeah, it's goes with the territory, I guess. But I think all of us are doing a very good job at balancing that and keeping our families happy.
Trying.
Oh yes, all you can do is try. And so, of course, now you're an attending, you're practicing, you've been through all the training, and so you have a fairly good understanding of what your life is today and the fulfillment you get from work. Is this something you would do again? If you were
given hindsight,
turn time back, 15 years, would you go in this field again?
I would definitely do it.
Okay.
And good so to hear.
Good. Thank
Reassuring.
God. and say I am a medical student interested in the field. What steps should I take to make sure that I really am interested in the field? And what paths should I take? And regardless, this could be it could be through neurology, of course, radiology or neurosurgery to get to neurointervention. But say I'm just a naive medical student and I don't know much about how I get there.
I think the key is to have enough exposure to this field during the medical school. They all have elective time rotations. This is what I did. I think the most helpful thing they can do is to use all of that elective time to explore their interest. And if they realize that they like this field, again, I would spend all of my elective time in the angio suite, because this is talking to people obviously gives you an idea of this job, and everybody knows that there are sleep interruptions, calls, stuff like that. But seeing the procedure over and over and see how we do stuff, like how we treat stroke or how we treat aneurysm, seeing those procedures in real time over and over actually gives you an idea whether this is something you want to do for the rest of your life or not.
Right.
And then as you go forward in the medical school, in the residency, in the fellowship, you realize that your interest is becoming like more prominent, or you're losing interest. So I think that there is no quick way about it. You just have to spend time in the angio suite.
Couldn't agree more. It's where it's happening. You got to see it in the flesh. You got to see the interactions. You got to see how happy people are or not, and you want to see if this fulfills you. And because as we've discussed many, many times, this is a field that unless you're in love with it, you will be really miserable in. There's no substitute for that. So that's very refreshing to hear. Well, Iman, it's been a pleasure having you here. And we're certainly looking forward to having you in more podcasts in the future to talk about all your special interests in treating neurological disease. But this was a good opportunity to introduce you to our audience and talk about all the amazing things that you do and what a great person you are.
And as they say, better late than never.
you know, it had to be on
Stroke month.
a stroke
That's
awareness
right,
month,
for
right?
our only dual trained
'cause he-
neurologist, for sure.
Yeah, because he came in August, so he was totally past the
Yes.
the stroke awareness month. All right, Iman, thank you so much.
Thanks very much for having me. It was great to be here.
Yeah, it was a pleasure. Thank you.
Thank you.